Good afternoon. It's a pleasure to be here, and I'd like to thank the organizing committee, the host, for putting together such a fantastic conference, and it's a privilege to be speaking among all these distinguished speakers. Today I'd like to talk briefly about the blood pressure and why blood pressure is important, and then talk about a little bit about the challenges we have in defining hypotension and the impact of hypotension on outcome. Then talk a little bit about the pathophysiology of hypotension or cardiovascular compromise and how that helps us to treat our babies. And if we have time, at the end, I'll talk a little bit about the newer methods of monitoring, hemodynamic monitoring, that can help us with babies with cardiovascular compromise. Now,
should be this one. The first one, the red one.
First one. Okay. I'm not sure if you can see from the back there. When you have a significant insult, let's say asphyxia or sepsis, then the patient condition can go through three phases of shock. First, compensated shock, where you have neuroendocrine compensatory mechanism activated, so maintaining blood pressure. Then if those mechanisms start to fail, then you go through uncompensated stage of shock, where you have hypotension. And if the problem persists, then the baby can go to the irreversible stage of shock, where you have multi-organ failure. And by looking at this, you can see that blood pressure seems to be a clinical sign, a main clinical sign that can tell us that the shock is progressing to uncompensated stage. And if we want to prevent shock entering the irreversible stage, then we need to recognize it early. And to recognize it early, it seems that recognizing hypotension would tell us that a bigger problem is impending. So that, and together with the association with poor outcome when you have hypotension, these two have served as a rationale for treating hypotension. Now, we know what is normal blood pressure, and we know that it depends on gestational age and increases with postnatal age. But we have very little information on what constitutes hypotension. Ideally, we want to know what is the blood pressure threshold below which the organ function or the organ blood flow, or more importantly, organ damage can occur. Unfortunately, we have very little information about those thresholds. But this has not prevented us from arbitrarily choosing some cutoff and then adapting it in our practice. Now, here are the list of the definition of hypotension that has been used. A mean blood pressure less than gestational age, a mean blood pressure for a population less than 5th or 10th percentile, or a mean blood pressure below a threshold of 28 or 30 millimeter mercury. And recently, permissive hypotension has been added to this list, which essentially calls for complete disregard of blood pressure value and deciding on treating the baby based on our clinical assessment of adequacy of perfusion and some laboratory tests like lactic acidosis. Now, I'd like to ask the audience, which of these definitions, or maybe a different definition, do you use in your practice? By show of hand, how many of you use blood pressure as a mean gestational age? Okay, and how many use 5th or 10th percentile according to some population, let's say Watkins data? Okay, and then how many use the threshold of 28 or 30 based on some data that affects the cerebral blood flow? Okay, and then permissive hypotension, not ignoring blood pressure completely. Okay, so it looks like the vast majority of the audience, 90%, 95%, are using gestational age as a cutoff, and that's the most common. And then few was using the other definitions. And that's fairly common, but it's interesting that that definition, as you probably know, came about by just arbitrarily choosing a cutoff. But there are some data that which we really don't dive into because we won't have time. But there is some data to support actually any strategy that you would choose. And you often hear what is important. The question is it flow or is it the blood pressure? The fact is that these two are related. If you look at the Poiseuille law, which governs the forces that move fluid around in the tube, you see that the flow is directly related to the pressure gradient across the tube and is indirectly related to the viscosity and the length of the tube. So from this you can tell that the blood pressure is the driving force behind moving the fluid, in our case blood, through the vessels. Of course, in clinical practice, we don't measure viscosity and we can't measure the length of the vasculature or the diameter, so we use Ohm's law. And that states that the flow is dependent on pressure gradient directly and inversely related to resistance. So it's important to realize that the resistance here, we lumped all the factors that causes resistance into a value which is a calculated value. So we don't measure resistance. So we have two things to measure, the flow and the pressure. And if you look at this formula and rewrite it, stating that the blood pressure is a product of cardiac output times the peripheral vascular resistance, then you will know the limitation of this, of blood pressure in estimating the flow. Because if you drop the cardiac output by 50%, but at the same time the vascular resistance doubles, the blood pressure would not change, yet you had significant hemodynamic changes that has occurred. So at least theoretically, it makes sense that blood pressure would not be predictive of flow. Now, the main function of cardiovascular system is the delivery of oxygen to meet the oxygen demand of the tissue. And to do that, the systemic flow or the cardiac output interact with systemic resistance to ensure the adequacy of oxygen to the tissue. And these two independent, relatively independent factors, systemic flow and systemic resistance, are regulated by endocrine, autonomic system, and a host of other physiologic and pathologic factors. And the interaction of these two will, of course, give us the dependent variable, which is the blood pressure. And when the flow is inadequate and it cannot keep up with the oxygen demand, then the tissue has some compensatory mechanism to fall back on, which is increasing capillary recruitment, and another mechanism is increasing oxygen extraction. So from this, you can tell that adequacy of blood flow to the organ is the goal in general, but the problem is we cannot ensure by clinical exam alone the adequacy of flow to the tissue. Like capillary fill time is not sensitive enough or specific. And the laboratory tests like lactic acidosis, that can be very specific, but it's a late sign. So that's why we are, again, back to blood pressure, because that's the only thing that we really can monitor. Now, we know from all the studies, virtually all of the studies that have looked at the population of hypotensive babies, pretty much all of them found that babies who are normal and don't have hypotension do better than the babies who have hypotension. What we don't know is what's the cause of the poor outcome. Is it hypotension itself? Is it treatment that we're providing, as some have suggested, or is the combination? Your baby has hypotension, is high risk, and we inappropriately treat the baby excessively or so, and we can lead to the problem. Or maybe hypotension is just a marker. You know, babies who have hypotension, they're generally sicker. They have other things going on, inflammation. And now to make things more complicated, a couple of recent studies have shown that actually there is no association between hypotension or indicators of hypotension and the outcome. Now, this study was a post hoc analysis of a prospectively collected data of a fairly large number of babies, and they looked at 3 indicators of hypotension: lowest quartile for mean blood pressure, use of vasopressor, or labile blood pressure. And these were very tiny babies, less than 28 weeks, in the first 24 hours. And they found no association between outcome at 2 years of age, a neurodevelopmental outcome, or cerebral palsy. So if you look at this, and you can conclude that there is no association between the two. But of course, depending on your bias, you could also conclude that vasopressor was not harmful because it didn't increase the risk. Or it may have helped some. That's why you didn't see any evidence. But so the fact is, from all the data we have right now, just like in the case of PDA, they really, you cannot determine the cause and effect relationship. So apart from that, there are other challenges. One is that the common practice of treating hypotension, most of us treat hypotension, whether we're right or not, that's a different question. The temporal relation to other factors that affect organ blood flow. Babies have hypotension when their PDA is open, and that may affect the flow. They usually have inflammation, something else going on, chorioamnionitis, necrotizing enterocolitis. And also, we really don't have a definition for hypotension, a true definition where the organ blood flow get affected. And I mentioned about lack of randomized controlled trial. We're actually looking at whether hypotension compared to placebo would make any difference. Now, the only study that have attempted to look at the effective treatment of hypotension is this recent study published in JP, where actually this randomized trial found that that randomized controlled trial is not feasible. So they had some over 300 babies less than 27 weeks, so these are very tiny babies. Very large number of babies, then only 10, they enrolled 10 babies in 1 year. And the main problem was that they couldn't get consent in timely fashion. So that was one problem, but that was not the only problem. If you look at the 58 babies who were eligible, out of 48 that were not enrolled, 85% of them received treatment. And if you look at the 20 babies whom the attending didn't even let, 20 babies who parents were not approached for the study, 13 of them, the attending didn't let them do it because they were concerned about hypotension. So our belief that hypotension is harmful is obviously is another factor. Now, I'd like to review with you a case of a twin, a 26-weeker twin who were born by C-section. No premature rupture of membrane, Apgars were good, and both received surfactant and put on conventional mechanical ventilation. Blood pressure and capillary refill were normal in the first week. So no evidence of perfusion problem clinically. Blood pressure looked fine. Here is twin A. Here you see this, the oxygen saturation. Green shows the near-infrared spectroscopy, oxygenation in the brain, so venous saturation. And this is the oxygen extraction, which is inversely related to flow. This was twin A, and this was twin B. Now, just looking at this, you can appreciate there is a different pattern. The B twin started with somewhat higher extraction, meaning probably lower blood flow to the brain. Now, we also looked at the middle cerebral artery flow. These two were part of a study. And you see that MCA flow velocity was fairly stable. Twin B had a spike at about 38 hours of life. Now, we were doing, every 12 hours, we were doing a head ultrasound to detect IVH. And the twin A had all normal head ultrasound. Twin B had a grade 1 IVH at about 36 hours and grade 4 at 12 hours later. So these two babies had normal pressure, normal perfusion, so they shouldn't have, at least from hemodynamic standpoint, should have not gotten an IVH. So what happened? Of course, we don't know exactly, but it may have to do something with this spike, which worsened the IVH from grade 1 to grade 4. But if you plot the CO2 for the first 3 days, you see that the baby who developed IVH, twin B, shown here in red, the CO2 of that baby was in general higher than the twin brother. And it also had a spike around 39, 40 hours of life, and also some very low CO2. And we know that there is a relationship, direct relationship between CO2 and cerebral blood flow. As others have shown, we also saw similar direct relationship between PCO2 and MCA mean velocity as a surrogate for cerebral blood flow. And this linear relationship existed with CO2 of 28 to 75 or 76. Now, these are very tiny babies, mean gestational age of 26 week, and but they were hemodynamically stable, so no pressors, and they were perfusion and everything looked fine. Now, what was interesting was that when we looked at the data by using piecewise bilinear regression, we found a break point in this relationship. So around 51 to 53 millimeter of mercury, there was a sudden increase in MCA mean velocity in relation to PCO2. So below 51, there was no relation between MCA flow and PCO2, but above it, there was a significant relationship. So in a way that increase in flow related to high CO2 may explain the reperfusion injury. And if you remember, the baby B, twin B, who developed IVH, also had higher extraction at the beginning, so he was probably more prone to develop IVH. And then when you have increased flow, he developed IVH. That's one possibility. But what is actually interesting is how is the CO2 related to blood pressure? And what it turns out that high CO2 it also affects the autoregulation. So if we look at the autoregulatory curve here, we see that for a certain range of mean blood pressure, the cerebral blood flow stays fairly stable. And so this line is fairly flat. Now, Kaiser and associates from Arkansas, they did some experiment, and they looked at very low birth weight infant when they were being suctioned. And they looked at their mean cerebral blood flow, MCA mean velocity continuously, and then plotted the change in mean velocity when the pressure went up from 30 to 40. And they plotted for different CO2 level. And what they found that when the CO2 was 30 to 40, this line was fairly flat, similar to what you see here. But when the CO2 went up, as the CO2 increased, the regression line became steeper. So meaning that with higher CO2, autoregulation progressively got attenuated. We found similar finding in our population, hemodynamically stable babies in the first 3 days. When we looked at the cutoff of 51 that we found earlier, we see that below 51, PCO2 of 51, there is no relation between mean blood pressure and MCA, mean velocity. But for CO2 above 51, we see a trend. Now we have a small number of babies. But in general, there was no relationship between pressure and the MCA flow for our population. But when we adjusted for CO2, we saw a positive, significant positive linear relationship. So even the baby is completely stable, we think, hemodynamically. Blood pressure is fine, perfusion is fine. Other factors are playing a role as well, like CO2. So autoregulation is really important. So to summarize this background, hypotension is associated with poor outcome, but we don't know the cause and effect relationship. And adequacy of organ blood flow is the most important parameter, but we cannot verify it by clinical exam and laboratory tests in timely fashion. And that hypotension should be only considered as one of the screening tools for adequacy of cardiovascular function, and not the only trigger. And that the duration of hypotension, impairment of autoregulation, and presence of coexisting derangement like hypoxemia, extremes of CO2, hemodynamically significant PDA, and metabolic acidosis, they all have been shown that augment the adverse effect of hypotension. So in this kind of setting, you have to be more careful in not treating the baby if that's what you're choosing. So let's say that you have decided that the baby needs treatment. Let's say that the baby needs to be treated. We have to follow certain principle to maximize our chance of helping the baby. Now, a lot of these things we don't have a real solid data to support one way or another, and what is the best way of treating the baby that can affect the outcome. We don't have that kind of data. But until we have such a data, we have to use the principle of pathophysiology and the information we get from the baby to tailor the care according to the baby. So we have to individualize care. One size fits all doesn't apply here to hypotension. So we need to target the underlying pathophysiology. We need to choose the right medication for the problem. So what is the problem? Is it contractility? Is it vascular tone? Is it volume? And we need to titrate the medication because the response, the pharmacodynamic is different from one baby to another, and it is affected by developmentally regulated mechanisms and downregulation of the receptors. And finally, it's very important to avoid overshooting. And I'll show you some data on that. Now, when you're looking at the pathophysiology of shock, you need to go back to the basic, that blood pressure is a result of cardiac output times systemic vascular resistance. And that cardiac output is product of heart rate times stroke volume, and that the stroke volume is determined by preload, contractility, and afterload, and that the vascular resistance is regulated by neuroendocrine and paracrine regulatory mechanisms. So we will talk about each specific component of this interaction and how can we classify and determine what to do for the baby. But for now, let's talk about choosing right medication. When we identify what is the pathophysiology, what is the underlying problem, then we can select the receptor that we want to stimulate to get to counteract the problem. And these are the common receptors that the medication we use affect. The alpha-1 and 2 vascular receptor stimulation leads to vasoconstriction. Beta receptor in the vessel result in vasodilation. You have a little bit of inotropic effect by stimulating alpha-1 in the heart. Beta-1 and beta-2 in the heart are responsible primarily for the inotropy and increase in heart rate. And the dopamine in the vasculature, selective vasculature, leads to vasodilation and has mild to moderate inotropic effect. And the V1A vascular receptor leads to vasoconstriction. So once you know what the receptor to stimulate, then you can choose the medication that fits the profile. And for most part, the medication that commonly we use in the NICU, they're both vasopressor and inotropes, albeit to a different degree. So we have, for example, norepinephrine, epinephrine, dopamine, they're all vasopressor and inotrope. And we have medication that are primarily inotrope, like dobutamine or isoproterenol. And then medication like phenylephrine and vasopressin that are vasopressors. Now, I mentioned that we have to be very careful about the excessive increase in blood pressure when we're treating hypotension. Now, this study is very important. It's a small study, but it's give a very powerful message, in my opinion. Here, the cerebral blood flow was measured by near-infrared spectroscopy, and on x-axis, you see the mean blood pressure. The black box, black squares are normal babies or babies with normal blood pressure, and the circle, open circle, are hypotensive babies before starting dopamine. And what you see here is that regardless of the blood pressure for the normal babies, cerebral blood flow was in similar range. But once the blood pressure was lower than a threshold, which in this case was 29, then the lower the blood pressure, the lower the cerebral blood flow. But what was interesting that once the dopamine was started, then the cerebral blood flow increased. Now, it's a double-edged sword. We wanted the brain perfusion to improve, and dopamine did it. The problem is, the higher the blood pressure, the higher the cerebral blood flow. So autoregulation was lost. And that's very important because when we're treating hypotensive babies, many of them have low cerebral blood flow. So they're more vulnerable. And in those babies, if we increase the blood pressure significantly, then we can have the reperfusion injury and overwhelm the germinal matrix. So that's a problem, and that's why some studies show or think that treatment is a problem, but I think that's part of the problem. So inappropriate treatment is also a problem. Now, going to the pathophysiology, we looked at this. We know that we are interested in determining. We won't talk about arrhythmia, but we'll talk about preload, contractility, afterload, and vasodilation, and classify the population with cardiovascular compromise into these categories, which help us in formulating a treatment plan. Vasodilation is one of the most common causes of hypotension in the NICU. Unlike in children, pediatrics, where hypovolemia is, in NICU, vasodilation is the dominant pathophysiology. And diagnoses like septic shock, systemic inflammatory diseases like NEC, their problem is primary vasodilation. Unfortunately, there is very little data in neonates on how this plays out. You know, does hypotension in babies who have septic shock, for example, is it primarily a vasodilation or not? This is one of the very little information that we have about it. This was a study on babies with sepsis, and they looked at the cardiac output and the SVR at the beginning, and then 12 hours later, and then when they got better, if they survived. And they divide them into two groups: survivors in blue and non-survivors in red. Both groups had high cardiac output, about 500 or so, normal being about 150 to 300 ml per kilo per minute. So they both had high output, and the resistance, both of them had low resistance, which is again confirming, similar to adult, that vasodilation is probably the dominant pathophysiology. But the babies who did not survive, they had this sharp increase in SVR compared to babies who survived, who had more gradual increase in SVR. Now, it's not clear that was the cause of the problem that they died, or actually this was the last-ditch effort of increasing vascular resistance to maintain perfusion pressure. But there was a different pattern. Now, not all babies or all pediatric patients who have septic shock, they have vasodilation. Like, if we look at this study where they compared children who had septic shock from central venous catheters, so these were in the hospital, shown here in red, compared to community acquired, those who were at home and then presented to ER because of septic shock. They see a different pattern. Babies in the hospital had the typical vasodilatory shock, but the babies or the children who presented at home to the emergency room, they had low cardiac output and high resistance. So there is a different pattern. Now, it's not clear what's the reason. One of the things that was brought up is they had different pathogen. The central venous catheter was primarily gram-positive, community acquired was gram-negative. But I think more importantly, the one who presented in the ER, there was some time lapse from the diagnosis to treatment, whereas the baby or the kid who was in the ICU was detected earlier. So that might have also played a role. So you could have different patterns still, but still I think vasodilatory shock is the dominant picture with septic shock. Now, the treatment for these babies are volume first, and then vasopressors. You want to improve the vascular tone. So things like dopamine and epinephrine would be good. It's a combined effect. And if those don't work, the second line is corticosteroid. But it's again important to recognize that babies can have different pattern. So you need additional information. But by default, I think these babies have vasodilatory shock. The second group that are common are babies who have poor contractility. And this group, the main etiology in this group are babies who have prenatal depression, asphyxia, or septic shock, maybe in the latest stage when they have myocardial dysfunction. And this group is very important to recognize because it can be tricky. Now I'm going to present you a case, and I'm going to ask you, what would you do in this case? You have a preterm infant who was born at 24 weeks of gestation. By vaginal delivery, there was prolonged rupture of membrane, but no signs of chorioamnionitis. Apgars were low. Baby received a brief period of chest compression. ABG initial one shows pH of 7.05, CO2 of 92, PO2 is 102 minus 5, base deficit is on conventional at 35%. Then the baby was switched to high frequency, and at 12 hours, this is the gas. CO2 is 37, PO2 47, minus 6 is the base deficit. Blood pressure 31/25, mean of 28, he's 24. Most of you by that definition that I earlier asked you would not treat. Capillary fill is fine, hematocrit is good. How many of you, by show of hand, would do any intervention for the hemodynamic part, not for the blood gas, for the hemodynamic part? Anyone would start a baby, give a bolus? Wouldn't hurt to give a bolus. No. Dopamine, dobutamine, epi? Okay, so most of us wouldn't do anything for this case. Now I'm going to show you what is the heart of this baby. We think from clinical picture, this baby is not in trouble. He had a rough time getting to this world, but now seems to have settled. But look at the left. Left is this baby at 12 hours, and the right is the comparison, a normal comparison. And I hope you could appreciate, even from distance, that this heart, this is the left ventricle, compared to this one, is really not moving much. So it's not contracting well. And if you look at the M mode, so look at the septum, this is the septum, and the posterior wall, they're not approximating, they're not getting closer to each other. So it's poor contractility compared to normal. And if you look at the right ventricular output, it's 49, normal 150 to 300. So this is a baby who is really in trouble. And that's a problem with the babies who are asphyxiated, that they may look okay initially. They have compensatory vasoconstriction, so your pressure might be normal. Now this is a different case, but in this baby, dobutamine was started, and you can see that the systemic flow, the velocity in the pulmonary artery, doubled after starting. And looking at the MCA flow, you see that the pattern normalized. So in babies who have asphyxia, first we have to recognize it and look at the heart. And second, maybe choose something that improves contractility, like dobutamine as shown in this study. Here? Actually, I'm not sure if yeah, I actually didn't put the information. I don't recall exactly what this patient had. I put here just to show you that the pulmonary flow improved, but there might have been some other things going on. This is not the same baby as the one that I showed you before. That's not the case. That's just a baby who received the dobutamine for poor contractility. But yes, it could have been a retrograde flow. But dobutamine is a drug of choice in this case that improve, at least theoretically, it would be drug of choice, and it's shown that it improves the contractility, cardiac output actually improves after 20 minutes, and the organ blood flow improves a few hours later. So in asphyxiated babies, as I mentioned, myocardial dysfunction with or without compensatory vasoconstriction is the problem, and the treatment is inotropes and avoiding excessive fluid bolus in those. The third group are babies who have high afterload. Babies, for example, if a baby has dilated cardiomyopathy, then you have increased afterload. But more importantly, relevant to us or on a more daily basis, are babies who have a problem with adaptation after birth. And that's been postulated that high afterload plays a role in these babies. And that's based on the sensitivity of myocardium. And in this, if you look at the relation between contractility and afterload, this is what you have, a normal relationship. So with increase in afterload, you have decrease in contractility. That's in children. In neonate, even term neonate, this regression line is much steeper, meaning that with a smaller increase in afterload, you have more dramatic decrease in contractility. The problem is to recognize this entity is a challenge. You need to look at the heart. Clinically, it's very difficult to recognize it. And then even if you recognize it, what would be the drug of choice? Both inotrope and lusitrope have been shown not to help much in that case. The fourth group are babies who have hypovolemia. And the hypovolemia, as a group, they're not very common cause of cardiovascular compromise. So you don't have that frequently cord accident or subgaleal hemorrhage. And the fact that there is no relationship or weak relationship between blood volume and the blood pressure, again, points away from hypovolemia being a significant cause of hypotension and cardiovascular compromise. Although recent studies of improvement in hemodynamics with delayed cord clamping suggest that increasing the volume, because 10 to 15% increase in volume with delayed cord clamping, can result in improvement in hemodynamics, which makes you wonder that volume may actually play a role, like shown in this study, where the SVC flow was much better, higher, in babies who had delayed cord clamping. And as you know, low SVC has been associated with brain injury. The second group that may have hypovolemia problem are babies after surgery with third spacing. They may have relative hypovolemia. Like in this case, this was a 1-month-old former 23-weekers who developed NEC with perforation, post-operatively received multiple boluses, and escalating dose of dopamine up to 25. This was for persistent hypotension and lactic acidosis, and the blood pressure, despite these measures, was 26/17 with mean of 21, and the base excess was -12. And this was the cardiac function. So if you look at the heart, you see that this heart is, I mean, you don't need to be an echo expert to say that this is really hyperdynamic heart, shortening fraction of 48. And the cardiac output, the LVO, was 240, which is in normal range, but this is a baby who's probably vasodilated, so that cardiac output is not enough to keep the blood pressure up and perfuse the baby. So this is a baby who would benefit from additional volume and some measure to improve the vascular tone. Now, the fourth group are babies who have diastolic dysfunction. And these babies, again, as a group, they're not very common. But one particular etiology needs a lot of attention because the management is really completely different than all other groups. And those are babies who have hypertrophic cardiomyopathy because of diabetic mother. As you see in this case, this is a fairly large baby who got into trouble after 2 hours with hypotension and metabolic acidosis. And if we look at the heart of this baby, we see how thick is the septum and the posterior wall and how small is the left ventricle. And here you see the apical view of this baby and a normal for comparison. And I don't know if you can appreciate it from the far how small is the cavity here, even with such a slow heart rate compared to this one, whose heart rate was only 150. So this baby was running about 100, still very small cavity. So these are the babies who have diastolic problem, preload problem, and get worsened by the dynamic left ventricular obstruction, outflow obstruction because of mitral valve movement. And these are the babies whose treatment would be volume, volume, and more volume. And then if that doesn't work, then something to slow down the heart, a beta blocker. And if that doesn't work, then something that increases the afterload, actually primarily just vasopressor like phenylephrine or vasopressin would be a drug of choice. And these are the babies who absolutely we want to avoid anything that has inotropic property. And the last group are the babies who have shunt, PDA, AV malformation, and this is a whole talk in itself. I won't get into the controversy of the PDA today. But I'd like to show you a case and see what you do in this situation. Now, this is a preterm baby, one of the twin A, who was born at 31 weeks of gestation. He was delivered because of abnormal cord Doppler, no signs of chorioamnionitis, Apgars were okay, baby had no respiratory problem, was in room air, normal gas, just had hypotension. And he received a bolus, 3 hours later still hypotensive. I mean, it's real. It's 34/14 with a mean of 21. So no matter what group you are in, I mean, this baby would qualify as having hypotension. What would you do in this case? How many of you, by show of hand, if I can ask you, how many of you would do no intervention because baby looks fine, just have pressure problem? How many of you would do no intervention, just closely monitor the baby? Okay, and how many of you would give another bolus? Okay, and how many would start dobutamine? Dopamine? Epi? So looks like many people started dopamine. Well, many, I mean, majority of people, 80% of the audience did not do anything. And about 15% that started dobutamine and few started other things. So I don't know what is the answer, of course, what should we do for this case, but we looked at the baby a little closer. So we looked at the heart to see what else is going on. And that's the left ventricle, and I apologize, I think it's not dark enough, you can't see, but you take my words for it, the contractility is really well. It has a good contractility. And if we look at the M mode, you see that the contractility is really good at 34%, shortening fraction, cardiac output 380, the duct was bidirectional in this case. And this is the middle cerebral artery flow, which looks normal. So with that information, we feel more comfortable not doing anything, no intervention, just closely monitoring. And sure enough, within 6 hours, we see that the blood pressure improved on its own and completely normalized 24 hours later. And as we expected, this was a baby who had good cardiac, too much cardiac output. So it was compensating for vasodilation, but not enough to get the blood pressure where we wanted. And with time, he improved the vascular tone. As the SVR went up, you see that the pressure improved. So it tells us that not all hypotensive infants really need treatment, but there is a big if. If we can ensure adequacy of organ blood flow. Now, I'm not suggesting that with looking at the MCA you can ensure that, but at least it gives you more reassurance. This is not a baby whose heart is not pumping like the first one I showed you. So it tells you more. And then if everything else is fine, completely fine, then this might be a baby that you actually can leave him alone. So we'll spend a few minutes talking about other methods of monitoring the baby. We really need to move beyond blood pressure and look at other methods. And I encourage for those who haven't done or not doing it yet to learn echocardiography. It's not rocket science. You can do it, and it tells you a lot about the underlying pathophysiology and a little bit about the flow and what to do about the baby. There are non-invasive for those who don't want to learn. There is non-invasive continuous cardiac output monitor that may be helpful. Tissue oxygen saturation, near-infrared spectroscopy, visible light. These are, I think, in a few years will be really, we could use them clinically for patient care. Now, I'm going to spend a few minutes talking a little bit about the continuous cardiac output monitor. This is one of the devices called Ascalon. This device uses the whole cardiac output monitoring is based on bioimpedance, which has been around for 40 years. This is a newer way of looking at it, a newer formula. It's very simple. I'm not going to bore you with how it works. It's though very simple to use. You only need 4 regular EKG electrodes. You put it on the baby, and you get your cardiac output. Now, we looked at 20 babies at 115 pairs of echocardiography and electrical cardiometry, this device measuring the cardiac output. And the average was pretty much right on as far as the cardiac output is concerned. But when you look at the data spread using Blunt-Altman plot, you see that there is more variability in agreement between the two. And you see that while the bias is very low, the limit of agreement is pretty wide. And since we use echocardiography, that's the only way that you can non-invasively assess the babies, and in itself has limitation, about 30% error percentage. If you adjust for that, you get a true precision about 31%, which is as bad as echocardiography. So, I think there is some promise. We just need to better study this device and see how it helps us in trending, not as an absolute measure. There is another device that the group in Toronto looked at. They looked at 10 babies, 97 paired, and they found similar spread, but interestingly, they found much larger bias. This is a different device. But what was good about it that they persistently, at least it was consistently under-reading the LVO by about 31%. So I think these two devices have potential and that need to be further looked at. Now, I'm not going to spend time on near-infrared spectroscopy, just to mention that this is there are trials going on use of NIRS to assist us with treatment of hypotension. There is visible light spectroscopy that is used, has shown in animal model to be helpful in detecting shock in early stage. We have very little information, but the bottom line is we need a better monitoring to first of all know if hypotension causes problem, treatment helps, and 3, how to titrate our medication. Unfortunately, many of us still looking just at the blood pressure or using clinical assessment of flow. We need to look at both, but also need to look at the pathophysiology. We again encourage you to learn echocardiography, which help us more in defining what is the pathophysiology and giving us some information about the organ flow. But the real help would be when we actually can monitor cerebral blood flow specifically, but all the organ blood flow, when we can monitor that and adjust our treatment accordingly. With that, I thank you for your attention, and I'll be happy to answer any question you have.
Flow, so actually